Okay, this is our review for billing for RNA at Blount and at Tennova North. So let's just start with the top. Please check whether you're at Blount or Tennova North and put the date of the week from Monday through Sunday and put a sticker here. If you don't have a sticker, then please put the baby's name and the medical record number and the date of birth. And then always make sure you put the date up at the top. So say today is Tuesday, 3/4. Okay, so the date today is 3/4, and you have, the day of the year up there, so that's fine. And you just attended a delivery of a baby that needed PPV. If there's any PPV at all, even a breath or two, then you put your initials here. And if you did any kind of procedures in the delivery room for a resuscitation, say that you, it was a crazy delivery, you had to intubate the baby, you had to give surfactant, so you put your initials in there for all the above: intubation, surfactant administration. You attended delivery, it's high risk because you gave a couple positive pressure breaths. If you did anything in the delivery room, you always check the modifier, so you can just put a check here, or you can put your initials, doesn't really matter. If you do a delivery attendance or high-risk resuscitation and anything in this box under here as far as care that day, you always have to put your initials here for a modifier, because this tells the insurance company that, yeah, I went to the delivery and I took care of this baby after delivery. Same person, same day, provided this service. So if you see the baby for the first time and discharge the baby on the same day, of course, the top code is yours. If you're just doing the new initial exam, tucking the baby in, talking to mom and dad, writing up a little H&P or a little admission note, then you put your initials there. The next day, baby's doing great, just had to have the PPV, intubation, surfactant in the delivery room, and then just was cured. I went to mom. That's not going to happen very much, but say that kind of stuff happens. This is just to show you how to bill the first day. The second day, the baby's a newborn, happy and well. Then we're going to bill for subsequent care. This just means you see the baby, you check labs, mom's staying, so you do that from the day. The next day, the baby goes home. You have to write a discharge summary because you did all this work on this baby the first day. So you do 99239. If you spend more than 30 minutes, then you just need to write spent 31 minutes on discharge, and that includes the time examining the baby, talking to mom and dad, writing the note, arranging follow-up with anybody, talking to case management, anything that you do to take care of this baby, no matter who you talk with or what you do, is time that applies to this discharge. Generally, if we need to write an H&P, we just say, hey, more than 30 minutes. If it's super fast, then of course you would do the less than 30-minute charge. So that could be a baby that was born with that situation. So let's say, so just to review, make sure if you attend delivery, whether it's just delivery attendance with no PPV and you're just, baby's happy and fine, so you're just gonna do your little charge up here, then that's all you do. And if, say, there's no intubation, there's no surfactant, there's no procedures, so you don't have to do 59. Again, if you do any of these, make sure you hit 59. It just tells the insurance company that, hey, I went to the delivery, and while I was there, I did this other thing too. So yes, I need to get paid for both of those things. That's all that means. Modifier 25, if you attend a delivery, whether resuscitation or not, and do any care on the first day, then you click modifier 25. So almost everything you're going to attend probably is going to be initials at delivery attendants, initials at modifier 25, and initials at initial care. Oh, and I'm struggling to put in my little text box here. So this is going to be your most common kind of billing. Okay, so let's just look at a couple other things. I'll delete those. Oopsie. If a baby, when a baby comes in, and I guess when you have this billing sheet going to the insurance company needs to know what you are charging them for, which is all these things. They also need to know, well, why are you charging me for these things? And so all the diagnosis codes tell the insurance company why you're submitting a particular charge. So if you go to delivery attendants and you don't have to do any procedures, you don't give any PPV, and then you're just going to see this baby for the first day, you're going to make sure you hit your modifier 25. And you'd have to say, oh, it was a C-section. So we're going to put this little X here, and I don't know how to do that on my form, so I don't know if you can see here. We'll just say we're going to highlight, check this little X here. And that means you went to the C-section. And because you went to the C-section, that's why you deserve to get paid. This box always has to be checked for every single baby, every single time, always. So just make sure that something in this box is checked. I hope I didn't change it by me messing around there. And then any other diagnoses that apply, click those. If the baby has ABO immunization, click that. If the baby's exposed to hepatitis C, check on that box. The baby during hospitalization has feeding problems, check that box. There's hyperbilirubinemia, depending on the cause. Breast milk jaundice, physiologic prematurity, check that. Hypoglycemia, check that. If you have a diabetic mom, check that. So anything that applies, just check that, and historically check that as well. All that does is just tells the insurance company that there was actually a reason for you to be there. It's also a way that we run reports based on what kind of problems we're seeing in babies. The state also runs those kind of reports. So it's nice to have those correct. Okay. So let's say we have a baby who, let's see, I think we've kind of talked about everything. So down here, let's talk about this. Say you're at Blount and you go to delivery, or Tennova, either one, and the baby is pretty depressed. So you have to do PPV, you have to intubate. If this all happens at your hospital on a calendar day, then you bill all this stuff at your hospital on the calendar day. If the baby does not get transferred to UT, let's do that. So this baby is not getting transferred to UT, but you had to do PPV in the delivery room. You had to intubate. You give the baby positive pressure breast for a little while, then you extubated in the delivery room, and you had to do CPAP, and you brought the baby over at Blount to the nursery, where you put the baby on a little nasal cannula for a couple hours, and you're monitoring the baby for a couple hours continuously, okay? So you're going to click that you did positive pressure, you're going to check or initial that you did intubation. You didn't have to do anything else. If you placed a UV, you do that too. If you did any of these procedures at all, check for the little modifier. You can put a check there or your initials. Because you're doing something here and something down here, you always want to hit modifier 25 as well. So in this case, this baby is going to the nursery and being on a high-flow nasal cannula on a monitor for a couple hours. So that means this baby is critically ill. So you would bill for critical care. Anytime a baby needs a nasal cannula, an NG, hold on, let's see. Anytime a baby needs high-flow nasal cannula or CPAP, you're billing for critical care or subsequent critical care. So say you kept the baby, say you admitted the baby at 10 p.m., had on a high-flow nasal cannula, the baby stayed on the high-flow nasal cannula until the next day at 4 a.m., and you took the baby off to room air. So you can bill critical care for if the baby was on high-flow nasal cannula or CPAP at any time and being continuously monitored on day 0 and on day 1, then that's what you bill for. So say at 4 or 5 a.m., the nasal cannula comes off, baby starts eating great, decided not to transfer to UT. Well, that day, this baby gets subsequent hospital care critical because he was on high-flow nasal cannula for a couple hours on that calendar day. You're going to observe the baby, make sure the baby does great. So the next day, the baby's now in room air, eating, doing well. So instead of critical care, because we're no longer on CPAP or high-flow cannula, the next day you're going to bill subsequent normal newborn care. And the baby does great. So the next day, baby goes home, you write an H&P, you spend some time arranging follow-up. So you're documenting a hospital discharge greater than 30 minutes. So that's what that baby would look like. So if a baby is needing high-flow cannula or CPAP for, say, an hour or more with continuous monitoring, I would use this code. If it's for 5 or 10, 15, 20 minutes, I probably would not use this code. That seems too aggressive. let's say 1 hour or more of continuous monitoring, high flow nasal cannula or CPAP, you build initial critical care for that first day. If the next day the baby's fine, the baby's in room air, the baby's eating, the baby's with mom, then you just bill newborn subsequent care the next day. Baby stays another day, same thing. The next day you bill newborn subsequent care. Then you're doing a discharge summary. It's taking a while, so you're more than 30 minutes. You submit discharge for the last day of hospitalization. Okay, we'll say the baby was born and same thing happened. You went to delivery, you had to intubate this baby because there was meconium and the baby was totally out of it. It was purple, had a little plum. And so you intubated, you gave some positive pressure breaths, but the baby turned around really fast, so you extubated, put the baby just on some blow-by and was doing pretty good. Went to the nursery, started working, and so you did put the baby in a nasal cannula. You keep the baby on a monitor. So you have the baby on a monitor for about an hour and a half or two. Baby does great, comes off the cannula and goes, you observe the baby for a couple hours in the nursery, does great, he takes a bottle, eats well. So because of that first couple hours where you were on a cannula, on continuous monitor, you submit initial critical care day 0. Then the baby goes to mom, does great, happy life, gets observed the next day to make sure he's well. Same baby. You intubate, you give some positive pressure breaths, you place a UVC. Let's say on this one you don't place a UVC. I kind of forgot about the UVC thing, but whatever you do, you bill for. So let's just say you intubate, you then extubate pretty shortly. So you're always doing your modifier 59 if you do anything in the delivery room, check that. Because you're doing this and something down here, you're always putting your modifier 25 there. So you intubate this baby, you extubate pretty fast, he's doing pretty well. He comes to the NICU and he's in room air, and he's looking great. And the only problem is he's breathing kind of fast. And you're worried about feeding him by mouth, so you're thinking, I'm not sure about feeding this little guy. So you stick him on a pulse ox, and he's sitting on a pulse ox, he's breathing kind of fast, you're kind of concerned about feeding him. You watch him for 2 or 3 hours in the nursery, and then he slows down and starts doing great. And you decide to let him eat. He takes a bottle, he takes 20 mLs, and you decide to send him back to his mom. It would be very appropriate for this baby that you watched continuously on a pulse oximeter for a couple hours to submit this charge, which is initial intensive care. This means a baby needs a 1 liter nasal cannula, or needs an NG tube for feedings, or needs IV fluids for a little while, or needs antibiotics, or needs a continuous pulse ox for a couple hours. Whether you had to stick a baby in a warmer because they're cold for a couple hours to warm them up, or whether you had to stick an NG tube in a baby and give an NG tube feeding because they were kind of puny, then they did fine after that, went back to mom, or whether you put an IV in for a couple hours and gave glucose and ran glucose continuously because of low blood sugar, this baby would get that first day of 99477. So say, baby does great, couple hours, you're off the IV fluids, blood sugar is normal, you stopped IV fluids, or you put the baby on a pulse ox for a couple hours to watch them, a couple hours later they do great, they go back to mom. So these kind of babies get this initial intensive care for the first day, and they're with mom the next day, so you get that subsequent normal newborn, you're at an H&P the next day, so you charge greater than 30 minutes. I hope that makes sense. Okay, so let's talk about what happens if these babies go to UT. Okay, here's the deal about UT. You guys bill everything you do here because you're doing the delivery attendance, you're doing the high-risk resuscitation, you're intubating, maybe say you're placing a UVC in the delivery room. If you place a delivery of UVC in the newborn nursery after delivery, you cannot bill for it. This has to happen in the delivery room for resuscitation. And if you do these things for resuscitation in the delivery room, you can bill for them separately. So say you're at Tennova, you do all these things, and then actually the baby's going to go to UT and be admitted right after you stabilize the baby, like 15, 20 minutes, 30 minutes after stabilization, baby leaves. Well, at UT, we're going to submit this code for initial critical because this baby is now on the ventilator, or he's on CPAP, or he's on a high flow nasal cannula. So at UT, we're going to bill this. So you cannot bill this at Blount or at Tennova because we're going to bill it here. And if two practices try to bill an insurance company for two of the same charges on the same day, they're going to think we're trying to commit fraud. They'll know it's just a mistake. It's not a big deal, but it could be considered fraudulent. So you just want to make sure that if a baby goes to UT, that UT will submit this bill, the critical care or intensive care bill, because the highest level of care hospital is the one that gets paid for that. So you can submit it, but honestly, it won't work. So I would just try to leave this blank if you send a baby to UT. Let's go back to the most common baby you're going to have, which is a normal, healthy baby that doesn't need all this resuscitation stuff. So you go to a baby, it's delivery, it's vaginal, there's prolonged rupture, so they call you and ask you to come. Baby looks great, does great, no PPV. You maybe give a blow-by for a few seconds, but baby's fine. So you just bill normal delivery attendants. And you take care of the delivery of the baby that day. He or she does great, and you discharge them home the next day. They're just happy and well, but they're a little jaundiced. And their bilirubin's like 2 points below light level, so you definitely want to check them the next day. And that's the only issue. You think they're just physiologic jaundice, maybe a little breast milk kind of mixed in there. So you're going to check, both of these guys. It's okay to check two. And the baby's going to go home. Well, then the baby comes back the next day. Say they went home on the 5th. They come in on the 6th after discharge. And on the 6th, they are going to come in for a weight check because they're breastfeeding and a billy check because you want to make sure they're not needing phototherapy. So what you do is you write in a code because we don't have it. See all these codes here? You're just going to write in a code up here until we get you a new billing sheet. It's going to be 99391. And that code means this is a subsequent follow-up after an initial visit to the hospital where you're following up to do labs or an exam or both. And so for this to happen, I would just say 99239 or 99391 on 3/6. Now, if we had this code in here, which we're going to get it in here somewhere, you would just check the 99391 and you would put your little initials, pretend like 99391 was right here. You would check 992391 if that's what that said. Let's just pretend like it says 99391 here. And this says post-discharge follow-up visit or something. We'll call it something like that. Under 3/6, you just put your little initials right there and say, yep, that's me. And then, of course, you need to make sure that you got your check for hypobilirubinemia or maybe poor PO feedings, if that's on here somewhere, slow PO. If not, you can always write it in there, but it's best to just find one that applies and check it. And so you would also submit this charge. And either you can make a new sheet and write this up here for now, say on 3/6 I did 99391, and I checked the box for slow feeder right here, and I checked the box for hyperbilirubinemia, physiologic and prematurity, or breast milk, whatever you wanted to do. So you have your charge and you have your reason for the charge, and then you submit that and you're good. Now, if you're going to do this charge and submit a bill for it, you can't just have somebody call you on the phone and say, hey, the bilirubin was 12. And you go, oh, yeah, you tell mom to go home. You don't bill for that. But if you bring mom in and baby, you look at the baby, even if it's like, a quick look, you check the capper you feel, you touch the tummy, you listen to the heart, it's just a very brief exam. And then you look at the baby's bilirubin and you have the nurse weigh the baby and you look at that. Then you need to write a note, a SOAP note, subjective, objective assessment and plan. Say, hey, subjective, this baby is jaundiced. So we checked the bilirubin today. DAT is negative. The bilirubin was 14 yesterday. It's 14.5 today. So baby doesn't need phototherapy. I'm going to discharge the baby home. That's your whole note. That's all you have to write. You can put more if you want to, but all you need is the basics. And then you submit that little note in the computer. And then you go to the billing sheet here. You write down code 99391 on 3/6. And you put your initials beside it. And you check what applies for the diagnosis. And you're done. And then if you write the note, examine the baby, look at the labs, write down the labs, write down that you talked to mom. Then you can submit this charge. Again, if it's just, baby comes in for a weight check, the nurse says, hey, I did the weight, the baby's weight's up 10 grams from yesterday, like, yay, tell mom to go home, then I would not charge for that. You can only charge if you examine the baby and write your exam and write down your assessment and plan and what the problem was the baby came in for. As long as there's an exam written down, the problem written down, your assessment and plan, even if it's one paragraph, that's 100% fine. So if you have any questions, please let me know. You can text me at 865-742-9692. You can email me, or you can just find me here in the hospital. You guys are awesome. We sure appreciate everything you do, and have a beautiful night. Thanks. Bye.